I'm Lorraine Brooks, and I'll be your host for today's show. My guest on today's show is Dr. Kathleen Powderly, a clinical ethicist and acting director of our Division of Humanities and Medicine here at the Downstate Medical Center. The topic of today's show is going to be advanced directives. And Dr. Powderly is going to talk to us about what an advanced directive is, why we each should have one, some of the history and where it comes from in the law and in the world of ethics. And I think it's an important issue because there's been a lot of talk in the press recently about end-of-life issues, advanced directives, how that impacts on all of our lives. And it's something that we really need to address if, God forbid, any of us find ourselves in a position where we're unable to make healthcare decisions for ourselves. So Dr. Powderly, welcome to the show, first of all. And my understanding is that in each state, there's a different requirement. And since we're in New York, why don't we start by talking about what the law says in New York in terms of healthcare proxies or advanced directives. Advanced directives is sort of a general term, correct?
Right. I mean, ideally in medicine in this country, the sort of the core principle of American bioethics is autonomy, that we will respect people's rights to make their own decisions. It's autonomy is self-determination, and we're talking here about healthcare decisions. The reality is that when we get to difficult life-sustaining treatment decisions, much of the time people have lost the ability because of they're critically ill or whatever else is going on with them, or they're elderly and demented, to tell us what they would want. So the idea behind an advanced directive is the ethical standard that we talk about is a substituted judgment, trying to figure out what this person would have wanted us to do. The idea behind an advanced directive, which is something you do in advance, so it's A-D-V-A-N-C-E, it doesn't have a D on the end, it's not advanced. It's something you do in advance that helps us to basically respect what your autonomous decisions would have been.
And autonomy is an ethical principle, or is it a legal principle, or is it both?
It's an ethical principle. It probably would be considered a legal principle as well. But I'm familiar with it from the ethical perspective. But then we have laws that talk about how that guide you in so respecting those decisions.
Okay, the laws kind of uphold the principle of autonomy.
But the idea is that you try to figure out what would somebody want, and if they leave some wishes in advance, now you can do that verbally, you can do it in writing.
If you do it verbally, what proof is there that you've done that?
Well, that's part of the problem then, is it's open to interpretation. There are different forms also of advanced directives, not only oral and written, but somebody could do, for instance, a living will.
What is a living will?
A living will is a document where you make statements like, I don't ever want to be on a respirator, or don't keep me alive with whatever.
That's specific.
It may be, yeah, but even if you look at the statement like, I don't ever want to be on a respirator, if you wind up in some kind of an accident and you have lots of surgery and you're in the ICU, but your brain is okay, but you're on a respirator because you've had a lot of anesthesia, but you're going to come off that respirator. That's probably not what you meant. If you wind up being now neurologically impaired and dependent on that ventilator, that's more likely what you meant, but the statement is open to interpretation.
Well, I think that to me seems where what they call that slippery slope is, because if you're saying to me that's probably not what I would have meant, there's really no indication that there's an absolute point at which that's not what I would have meant.
And therefore, a lot of times living wills, even well-intentioned clinicians will struggle to figure out, is this what this person meant? What's missing, what would make that more effective is if you also indicate, here's the person I want you to talk to if my wishes aren't clear. If you're not sure what I would have wanted. Here's the person I empower to make my decisions for me. Now, I think a lot of people assume that if they have a spouse or if they have a close relative, that that's the person who would make these decisions. And the reality is that the law does not necessarily support that, especially in New York.
Supported in what way? That would not be the obvious person to make your
in
decisions
New York,
for you?
and there's a reason that there are really 50 different interpretations of how much of this evidence you need, and that's based on a Supreme Court decision. There was only one right to die case that ever went to the Supreme Court,
And that was
the case of Nancy Cruzan in 1990. And Nancy Cruzan was a young woman who drove off an icy road in Missouri one night, was revived some minutes later by the paramedics, and went on to be diagnosed as being vegetative, a state in which she lived for a number of years. Her husband divorced her. Her parents kept going to court saying she wouldn't want this. Not, we don't want it for her. She wouldn't want this.
She wouldn't want what? To be kept
To be
alive
kept
by
alive by
artificial
artificial means. And
Okay.
she had never done a living will, which would have been in and of itself a legal document in Missouri. It actually would not be in New York. So they kept trying to establish her wishes. The Supreme Court said that it basically left us with 50 different state standards, because it said the state could determine as narrowly or as widely as it chose how much evidence of a person's wishes you needed. Missouri is the most conservative state. New York is the second most conservative. Florida, where there's been a great deal of debate recently in the case of Terry Schiavo, in fact is much more liberal in its law than that.
Meaning that New York requires a higher standard of proof.
Yeah.
Okay.
And so it left us in a pretty conservative place for people who don't have a healthcare proxy, which is the legally recognized form of an advance directive in New York State. Happened to be passed, that legislation, around the same time as the Cruzan decision. So a healthcare proxy is the legally recognized form of an advance directive.
Okay, so now let me just clarify for 1 second, because you've said a couple of things. Advance directive is a general term of which healthcare proxy is a type, and a living will is another type. Okay, so to say that you have an advance directive could mean you have a healthcare proxy or a living will, or both, right? Is there ever a case where both would be more appropriate? Okay, so you can, in fact, have both. And is that what you would recommend, to have both? What is the difference between the two?
And most people don't have any. Even in I speak on this all the time, teach this all the time. In a room full of doctors, I'll ask them how many have done a healthcare proxy. And before the case of Terry Schiavo, I'd be lucky if I got a few people raising their hands.
Is that because people don't understand the need for it?
It's because people don't want to think about dying. Partly, they don't want to talk about dying, and because they don't understand the need. I think there has been much more interest now, and that's a good thing, I think. The other thing is people assume, I think, that, well, it's, whoever my closest person is to me, that they're going to make these decisions. In fact, when people really think about it, they may not choose the person closest to them. It's a heavy emotional burden and psychological burden. It's difficult to do. And sometimes the person closest to you is not the person who, they may not share your beliefs. They might keep you going when you didn't want to be kept going. They might not keep you going if you did want to be kept going.
But if there's but that's a good point. If I have a clearly stated document that says, I do not want to be kept alive by artificial means, including a respirator, including a feeding tube. If that is my wish, and you have that in writing, signed by me, as a document, how then can you, as my proxy, justify not doing that? I mean, I know what you're saying.
You
there
can't,
are people
unless there are circumstances that may leave that open to interpretation.
So I have to make sure that if you're my proxy, you're going to abide by my wishes. It's not just that I'm going to tell you my wishes.
Right. I mean, there are two schools of thought on filling out a healthcare proxy. Some people say, be as explicit as you can about what you would or would not want, so that the person does exactly what you would have done in the situation. Other people say, don't encumber them with a lot of, in this case do this, and in that case do that, and in this case do this. Let them make the best decision that they can make with the information that's available at the time.
And knowing who you were and what you would have.
Right. So and I think that's a personal choice. The document, this is a New York State Healthcare Proxy Form. And as I said, this is particularly important in New York because our law is so conservative. And given the events in the legislature in Florida and the fact that this is now on the federal radar screen, having gone before Congress, my hunch is that our laws are going to become more conservative, not more progressive in this area. in terms of at least requiring something in writing. You don't need this special form. You can write this on a piece of loose leaf paper. You can have it photocopied. You don't
Does it
need
have
to
to
go
be
to a lawyer,
notarized?
and you don't need to go to a notary.
Okay.
In fact, the few healthcare proxies or advanced directives that I've seen that don't meet the few requirements of the law in New York have been done by attorneys and notarized. Because if this is not your area of the law, elder care attorneys tend to do these very well. People who do estate planning tend to do them very well. But if you do real estate law, you're probably not going to know what you need to do. In order to do a healthcare proxy, you have to be 18 years of age or older. You have to have enough decisional capacity to understand what it means to give your decision-making authority to someone else. So we call it sometimes situational capacity. Sometimes you'll have, for instance, an elderly person who is clearer at some times of the day than others, who may not be able to make complicated healthcare decisions, but has enough decisional capacity to understand that they can't make those complicated decisions and to be able to indicate who they want to make them.
Who makes the determination about a person's decisional capacity?
Well, at the time that you do a healthcare proxy, that you fill out a healthcare proxy, it actually has to be witnessed by two people, 18 years of age or older. And what they're attesting to is that you were not coerced, you were not forced to designate somebody, and that you had enough decisional capacity at the time to understand what it meant to give your decision-making authority to someone else. The presumption here is that we're respecting autonomy. So unless we really think somebody's acting in bad faith, and that's why it has to be witnessed, so that we know that somebody wasn't totally out of it or wasn't forced to designate somebody. So you have to be 18 years of age or older. You have to have enough decisional capacity to understand what it means to give your decision-making authority to someone else, and it does need to be witnessed. You have to sign it. You have to date it. That's really pretty much it.
What if you change your mind at some point?
If you change your mind, then you can change it. You can do a new one. If two of them show up when you're in the hospital, the one that's most recently dated is the one that's valid. You can also make statements about things that you would or would not want. And again, I think it's important, this is a document of empowerment. It's a document where if you did feel strongly that you would want to be kept alive with a ventilator or a feeding tube because that quality of life is acceptable to you and important to you, and in the very culturally diverse and religiously diverse community in which we work, that's a very important point, that people know that this is a way for them to say that as well. So you can.
What happens if you don't have any healthcare proxy? What happens if you don't have any of these documents?
Then it's very
It's a
hard to
medical
withdraw or
decision.
withhold life-sustaining treatment.
Okay.
That's the bottom line. And I think it's going to get harder, not easier, because of the recent events. Now, there's one area where it is important to make some statement, and that's the area of artificial nutrition and hydration. In a compromise with some pro-life groups that actively fought this legislation when it was going through, you do need to have reasonable knowledge of the person's wishes regarding nutrition and hydration.
And what is
Reasonable
nutrition and
knowledge
hydration?
is not as stringent a legal standard as clear and convincing evidence. The healthcare agent who's designated in this healthcare proxy can make decisions as if they're you. So if I'm the doctor and you're the healthcare agent, I would sit down and say, here are the things that we can possibly do. Here are the relative benefits and risks. Here's what will happen if we do nothing. Just like the informed consent conversation you would have with a patient. You would have that with the agent. The agent does not have to prove to you it's the decision the patient would have made if the patient hasn't left very explicit wishes. And they make the best decision they can at the time. And unless they're obviously acting in bad faith, you know, somebody who says, let's get this over with, I can't wait to inherit grandma's house.
Right, okay.
You know, to use a crude but clear extreme example. In that case, the hospital would have to go to court to remove the decision-making authority of that person.
Okay.
But otherwise, they make decisions and they don't have to prove it's what you would have wanted. With nutrition and hydration, they must provide some evidence of your wishes regarding the artificial administration of food or fluids.
Now, why
Feeding
is that a different
tubes,
standard?
That's just the compromise that was put in there in order to get the legislation passed. Because there's this kind of emotional difference for some folks around nutrition and hydration. And so in order to get the legislation passed, there had to be that caveat. And so in your healthcare proxy, you should either say, I would or would not want to be maintained with artificial nutrition and hydration if I were irreversibly comatose or permanently vegetative, or you can make the statement, my healthcare agent is aware of my wishes regarding nutrition and hydration.
Okay.
And that covers them, that
covers
empowers them. And again, the healthcare the person you designate doesn't have to sign this document. A lot of times they might not even know that they were designated.
Okay,
Now, hopefully when people do this, they talk to the person who they're designating. As I said, sometimes it's the closest person to you, sometimes it's not.
Can you designate your physician to be that person?
If you can designate your physician, but then your physician cannot act as your physician.
In that instance.
Right.
Okay.
They must, so for some people they would say, that's who I want, my family doctor. But then if they assume the role of the healthcare agent, because you can't make decisions anymore, then they cannot be your physician.
Is there ever a time when artificial hydration and nutrition is given to someone who does have decisional capacity, or is that always done when a person is in a vegetative state or in a
No,
coma?
it might be, and it might be withdrawn. But
And
then
it
it
can
would
be
be, if somebody's got decisional capacity, then they consent to having it, to having the tube placed. They consent, or they say, take it away. And again, those wishes should be respected if their capacity is not in question.
What if a person is not 18 years of age? What if a person with a terminal illness is not 18 years of age? What do we do then?
We have a big black hole in the law in New York for children. In general, we give parents a great deal of latitude in New York about decisions for their children. How they educate their kids. You can have them homeschooled. You can have, you have to educate them, but you have options. We give them a lot of latitude about routine healthcare decisions. As long as their kids are getting some healthcare, we let them maybe choose, some alternative things or whatever. But with the withdrawal or withholding of life-sustaining treatment, there is no clear recognition of parents as appropriate decision makers for children, with the exception of a do not resuscitate order.
There's some age, though, at which we consider children as having some decisional capacity as well, isn't there? I mean, we allow children to make decisions concerning birth control and
emancipated
drug
minors. Really, even an emancipated minors can make decisions about issues related to reproduction. Or drugs,
testing,
or
right.
HIV testing, termination of pregnancy, treatment for sexually transmitted diseases.
Right. Okay. What's the age group for an emancipated minor, or what? It varies.
Adolescence, right?
Okay.
I mean, there's some lower limit, sometimes recognized in the public health law, but in general, adolescents can seek treatment.
So why can they not perform this?
There is legislation that's been pending in New York State now for, I believe it's 13 legislative sessions now, a Family Decision-Making Act that would provide a mechanism for emancipated and mature minors, for foster children, for children, and for people without healthcare proxies who have identifiable surrogates, who have family members around them who seem to be struggling to make good decisions. That legislation had some promise of being passed this year after many, many years of being fought by some pro-life groups that were concerned about withdrawal of treatment from potentially vulnerable people. I mean, there is something to be said for that argument. My hunch is that in the aftermath of Terry Schiavo, that it won't pass this year, and that we're left with some real gaps in the law in New York regarding some of these things.
Talk about a living will for a moment as opposed to a healthcare proxy. What are the differences? Why should you, in fact, have maybe both?
Well, living wills are really documents where you say what you would or wouldn't want.
As opposed to a healthcare proxy?
The healthcare proxy really has components of both. You can make statements about what you would or wouldn't want. The most important thing in a healthcare proxy is that you designate your surrogate
Okay.
decision maker, your healthcare agent. But you can do that without filling out any of the rest of it. Although, as I said, you should make some statement about food and fluids. And there are some living wills that are specific. For instance, especially during the height of the AIDS epidemic, there were living wills that addressed specifically issues that might be of concern to a person living with HIV disease. Somebody
Such
who might have had recurrent bouts of pneumonia, who might want to specifically say, if I wind up in the ICU and you can't get me off the ventilator, then, I want you to take me off, or I don't want you to put me on, or whatever.
You would say that based on the nature of your illness.
Right, and you would have those conversations with your doctor. Is there something specific based on my end-stage renal disease? Should I talk specifically about dialysis, or my HIV disease, which has affected my lungs, or my cardiac disease? You could be quite specific. So it's really your doctor you should talk to about this stuff, not a lawyer. You should keep people off and say, what do I do with this thing when I fill it out? And you should make copies. Copies are okay. You don't have to have the original. The patient rep people, you produced actually a wallet-sized version of what you needed for a healthcare proxy and said keep it with your insurance card. They'll always look for that. So you should give a copy. Hopefully you're not required to, but you should give a copy to the person you designate. You should keep a copy with your personal papers. You should give a copy to your primary physician. Federal law requires that if you're admitted to a hospital or a healthcare facility, that you be asked if you've done an advance directive. And if you have not done one, that you be given information on how to do one in the jurisdiction that you're in. So in New York, it would be a healthcare proxy. But that's when you're admitted to a hospital. You got a lot of other stuff going on. So the best time to do it actually is when you're not sick.
And you can, you raised a good point, you can be very specific if you know you have a certain condition that might lead to certain treatments in the future. You can be very specific about what you would want in terms of that particular condition, and that's a good point. Is there anything else you would recommend that everybody do at this point? Everybody can do a healthcare proxy. Everyone over the age of 18 can do a healthcare proxy and a living will. Is there anything else you would recommend, or are those two things?
No,
really
I
the
think
most
doing those
important?
things, and I think engaging in conversation with the people close to you and with your doctor is really whoever you go to for your primary health care, your clinician, is really a good start. And I think people are going to be doing that more. One of our medical students suggested that we incorporate into the history that we teach them to take of patients. We ask them who they live with, and we do social histories that we incorporate in there. Have you done an advance directive? Well, if you ask people, who would make your healthcare decisions if you weren't able to? Most people have an answer to that question. What they don't realize is that person is not legally empowered.
What
and
about
this is a
people
way to
who
do
have
that.
no living relatives, or are, what do they call them, the unprotected elderly, or
Well,
something?
that's actually one of the unbefriended.
Unbefriended elderly.
There's
right.
actually, or they don't have to be elderly.
True.
They're actually, again, the legislation that's pending addresses the issue of those people who are potentially very vulnerable to either overtreatment because there's nobody to say stop, or undertreatment because there's nobody to advocate on their behalf.
So those people are particularly
vulnerable.
should have
And
these kinds of directives.
And I think they have to be encouraged to try to identify somebody who they would trust to make the decisions for them. And that pending legislation talks about things like ethics committee, kind of review to make sure everybody's acting in good faith and that kind of thing. But again, that hasn't passed, and I don't have I'm not optimistic now that we seem to be requiring much more in writing in the light of the S.U.N.Y decisions.
Just quickly, the S.U.N.Y decisions you're referring to are the decisions that upheld her husband's
the fact that
right
there
to-
was just so much turmoil when it was fairly clear and fairly consistent, over 30 court decisions by the time it was done, that she would not have wanted to be maintained artificially with this nutrition and hydration, and that her husband was her appropriate legally recognized guardian. The fact that those wishes were not in writing brought this back to the court over and over and over and over again, up to the level of the Supreme Court, which declined to hear the case 6 times. So I think that we're probably going to be requiring much more in writing than we might have before.
So if there's any lesson that we can take away from Terry Schiavo and Nancy Cruzan and the other cases that have risen to that level, if there's anything that we as average people, citizens, can take away, it's we need to have a healthcare proxy or some sort of advance directive, a living will, a healthcare proxy. We need to talk to the people closest to us and let them know what our decisions would be, either for or against being sustained on life-sustaining equipment. And we need to think about these issues and talk about them more. There's now a national dialogue about it, and this is a good time to keep these issues in front of the public. Well, thank you very much, Dr. Powderly, for being on today's show.